Welcome to CVI Heartbites. My name is Eduardo Rame, and I am an advanced heart failure, transplant, and mechanical circulatory support physician in the Philadelphia area. The topic today is supporting cardiopulmonary failure in COVID-19 patients from O2 to ECMO. And just a quick announcement from CVI. Due to the rapidly changing information and dynamic of COVID-19, this session is up to date as of June 17th, 2020. CVI Heartbites is not an accredited educational program, and CME-C credit is not offered. Again, I want to thank the organizers, the ability to present this topic, which is very timely, as there's been a lot of developments both in understanding how ECMO, extracorporeal membrane oxygenation, can be applied to really support patients with acute and severe lung injury, as well as you'll see in the last several slides, how to support patients with cardiopulmonary collapse with veno-arterial ECMO. The pathobiology of COVID-19, now I'm not going to be delving into this. It just basically needs to be fully appreciated that it's not completely understood. It's a complex, yet to be fully elucidated pathogenesis. We know we start with multilobar infiltrates and a ground glass pattern by CT scan, often in the early days. Now we're testing so many patients, but in the early days, that was the clue to make sure we tested patients for COVID. Very controversial is this idea that there are two phenotypes in this viral pneumonia. This normal compliance, or L phenotype, for low elastance, and decreased compliance, H phenotype, for high elastance. Whether it's a time dynamic that presents these two and there's still a continuum in the disease state is not clear, but it's important to note that the hypoxemia can be very severe even though the compliance is not compromised. Very, very important. Critical care physicians believe that the lung injury in ARDS is, the lung injury in COVID is ARDS and it's business as usual. Others think there's more nuances here to be appreciated. National requirements can quickly escalate along with the work of breathing. And another controversial topic here is whether or not is that due to, for example, pulmonary emboli, subclinical, pulmonary emboli that are maybe not being diagnosed, or microthrombi that are being complicating the already acute lung injury. Very controversial topic. Here is a schema just to bring everybody up to date. We do have pathogenesis that's already somewhat understood. We have the SARS-CoV-2 virus, just like the SARS-1 virus, attaches to the ACE2 receptor. It's the ACE2 receptor is not only in the endothelium across many organs, and that's why COVID viral infection can be so pan-organ prevalent. But also there are type 2 pneumocytes, and you do get infiltration into the lung. Importantly, there is a loss of endothelial integrity that is important to appreciate in COVID, and that will, I believe, be an important mechanism to directly target. Due to multiple other concerns, including cytokine-mediated inflammatory activation, a cytokine storm to some degree, and you get multicellular infiltrates, including macrophages, more organized inflammation, as well as lymphocytes. And finally, you get this microthrombi due to the activation of the coagulation cascade. This is yet to be fully appreciated, but we know there are several ex vivo pathology specimens from lungs that have showed that these patients do have a lot of microthrombi and small vessel thrombosis, as well as large vessel thrombosis in the setting of pulmonary embolus. This leads to worsening hypoxia and, again, ischemia throughout the organs and more multi-organ failure. Here's a case that was reported actually from nearby Abington, from Jefferson Health. This case of a young woman who came in very symptomatic with COVID pneumonia. This is her chest x-ray, a prompt presentation. She comes in and she has an oxygen requirement, but it quickly gets better. On the day she's about to get discharged, she ambulates, and as you can see on the CT scan on the right, she actually has a saddle embolus and a pulmonary embolus significant enough to be called saddle embolus that was at this point not hemodynamically compromising as far as blood pressure, but she was quite ill. She was treated with full dose enoxaparin, and You can appreciate an enlarged right ventricle on the picture on the left, and on the picture on the right, you can appreciate a significant degree of tricuspid regurgitation. With full dose enoxaparin, this woman recovered and was sent home despite having a pulmonary embolus. So what about shock? What about severe critical illness in COVID-19? It is business as usual as far as what we know what to do with patients in terms of support, going again from oxygen to ECMO, which is the theme of this talk. But importantly, there's more of a time-dependent organizational component here that really requires multidisciplinary teams to come together. And the reason is because, yes, the exposure to COVID must be minimized, but we have to take care of our patients. And so in clear guidelines, the European Society of Cardiology, along with the ACC and American Heart Association, have put out that for invasive coronary angiography, especially in the setting of shock, needs to be determined on a case-by-case basis. You could use thrombolytic therapy, probably not in shock. That's probably not advisable. So again, using your cath lab, mobilizing your cath lab if someone's having an acute myocardial infarction with cardiogenic shock, even in the COVID era, very, very much what most centers are doing. In patients with concomitant COVID-19 infection, it's important to note that if you're going to escalate to mechanical circulatory support, partial support systems like percutaneous LVADs or ECMO, you must weigh the risk and benefits, especially given this question mark that's looming out there, but seems to be more ominously true, that there's thrombotic proclivity associated with COVID-19. If you do need mechanical circulatory support, ECMO has been the preferred temporary support because of the ability to access quickly at the bedside if you need to, in terms of cannulation. Again, in patients who have a requirement for VV ECMO because of worsening lung injury, if they get into trouble with increasing inopressor requirements, and especially if you are vigilant for RV dysfunction, which is a recommendation from a lot of our colleagues from Europe and now the United States as we're getting more experience, you see that there's evidence of RV dysfunction, work up and see if there's a pulmonary embolus and see if compensating this can improve the patient's status. Obviously, early CRT in the right patient, obviously young, a good candidate for CRT, otherwise without too many comorbidities, should be done as soon as possible if the patient becomes oliguric. Many different scoring systems have been done for sepsis and ARDS. There's really nothing that's been validated for COVID yet, but it should be the standard in the team to try to develop some kind of organ system failure scoring system. Here at Jefferson, there was a development of a SF ratio, because not everybody had a blood gas. And so an SF ratio less than 150, and that's a saturation of oxygen over the FiO2, began to be something that we saw in our COVID-19 dashboard. Again, the safety of the healthcare personnel, predominant importance in trying to manage these complex patients who need a lot of support. So the kind of support we're talking about here is VV ECMO and VA ECMO. And under VV ECMO, I just want to make sure and clarify some lingo here. We have, for example, a patient that is in septic shock and basically also requiring more support. They can go from VV to VA ECMO, especially if there's a cardiogenic component. Veno-venous ECMO, which is usually cannulated with a femoral and a jugular vein approach. You basically have drainage from the femoral RA site, and you are returning to the oxygenated blood to the upper part of the body through the jugular venous cannulation. There's also, if you need basically a configuration where you switch from VV ECMO, you switch to V-VA ECMO, again, in the setting of more circulatory support requirement and more compromise. In terms of VA ECMO, one important point here is you could, in case, especially if you get into the issue of needing a higher degree of circulatory support with higher blood flow requirements, you could go into a configuration where you do a double drainage venous cannula, and this is called VV-A ECMO. So the early experience from China, this was very discouraging. A lot of us heard from many, many centers. In fact, we were very much challenged by our administrative colleagues, which for good reason. Do you really want to do ECMO? Do you really want to do ECMO given the outcomes in China? And let me just say, I'm going to summarize it like this. The early experience was not good, but perseverance amongst many of the clinical teams across the world and the power of Zoom, which we're using right now, came to bring a lot of us together to try to understand what we can do to provide this therapy for the most sick patients with COVID that otherwise would have had a nearly 100% likelihood of dying. So the International Consortium for COVID ECMO, ICE, is now more official, but it started 14 weeks ago with a overview with several of us that began to learn from each other. We learned a lot from colleagues at La PTA in Paris, as well as France, as well as Italy, and basically we began to just facilitate and extend this to lots of other colleagues throughout the U.S. So why ECMO? Why would ECMO work in this instance? Just very basic premise for those of us who are in cardiology who may not do as much VV ECMO. You want to improve oxygenation when the patient really has exhausted all the strategies to compensate and get a good oxygen level in their blood. The second is as important, if not more important. You want to facilitate extended lung protective ventilation. What this means for a lot of our critical care experts is you basically, through several databases, including the EOLIA trial, which was a randomized trial of ECMO, VV ECMO versus ongoing standard of care with mechanical ventilation, the patients who benefited the most were the ones who were hypercarbic despite maximizing lung protective ventilation, meaning that if you're at that edge and you needed to put someone on better oxygen and CO2 gas exchange support, these patients really benefited, and then you can really go into a lung protective strategy, quote unquote, lung rest. So several colleagues began to develop inclusion criteria. This is a courtesy of Dr. Ali Banayosi. He basically developed, and again, you're welcome to email me and I can send several of the criteria that have been developed here in Pennsylvania and other sites. But you, of course, EOLIA criteria applies here. Severe hypercarbic respiratory failure, especially if your FiO2 is under 80%. Severe hypoxemic failure with a PEF ratio less than 100. And, you know, age-relevant inclusion was put forth. Obviously, also how severe the patient was in shock. For VV ECMO, it was less than 8. For VV ECMO, less than 15. It's just initial parameters. Again, this is as of April 1st. These are criteria that were developed early. I'm giving you a sense for what we were dealing with early as far as trying to make sure we had enough resources to support patients. Exclusion criteria obviously had an active DNR order. If you had chronic pulmonary disease that was significant enough, especially to require oxygen, multi-system organ failure, especially liver disease. And importantly, if you had acute kidney injury, this was just a relative contraindication. It's important to understand that with COVID, a lot of patients went into acute kidney injury with a very recoverable, in a large proportion of cases, the kidney injury would be recovered if the patient was able to be supported appropriately. So why not do ECMO? One of the early reasons was because it absolutely could make the whole inflammatory condition of COVID worse. And this was the theory that was put out, that you had an overlapping degree of, for example, biomarker profile. If you see here, you'd see that with ECMO, you have, you know, a leukocytosis, but a lymphopenia, very significant with COVID-19, especially in the T helper cell, as well as a natural killer cell subsets. You also had a hyperinflammatory state, as they called it, in COVID, and you also induce inflammation with ECMO. So it was felt that maybe this wasn't the best therapy for such a inflamed condition. So started with very, very cautious centers that were trying to approach this question of how to support patients. And this is just to give you a snapshot. This is March 28th, 170 cases. This is the Euro ELSO consortium for COVID. And this is a registry kept by colleagues in Italy, across Europe. And this is just to give you an idea, March 28th, 170 cases, very early. The mortality appeared to be reasonable. And fast forward now to June 14, and we have 1,300 cases. 1,300 cases as of June 14th in Europe, at least collated through this registry. Importantly, you have 686 patients weaned from ECMO. You have 451 who died while they could not be weaned and died on ECMO, and then 51 who died after being weaned from ECMO. So let's say a total of 500 who have died. This gives you approximately a 60% survival in a real steady state now with these numbers. And just to be clear, what was the learning curve that we applied to achieve these results? All together through these conferences that we hosted, for example, our Philadelphia teams, Jefferson, Penn, and Temple, we hosted these conferences worldwide. The most important lessons came from Paris and other centers, including Japan, which is you need to use large cannulas. Large cannulas allow you to have a higher flow rate, which, as we know from Burkhoff's trial, you're going to decrease thrombotic proclivity. More aggressive anticoagulation, that's very controversial. Early and frequent bronchoscopy, because these patients are often infected, co-infected with bacterial sepsis. And proning, continue to prone them on VV-ECMO to see if you can improve, ultimately, the lung injury. This is an updated, just recently published article in the Blue Journal, the American Journal for Respiratory and Critical Care Medicine, 17 cases that were just collated in the center in Strasbourg, which of course saw an early hit from COVID-19. What did they find? These 17 cases of VV-ECMO comprised about 4.5% of their COVID ICU patients in Strasbourg in their 5 ICUs. They had 16 were VV-ECMO, 1 was VA-ECMO. The survival was 65% at 60 days. Again, very similar to what the Euro-ELSO numbers looking like very early. The difference here is this is 60-day survival. This is truly going to be potentially a durable number as far as these patients doing at least well from a survival perspective long-term. 70% survival, by the way, in the VV-ECMO alone, and 7 patients were discharged home. Here's their time course again to the 60 days, 7 patients discharged home, and in this case, 6 deaths out of 17 and 5 deaths out of 16 in the VV-ECMO case. The criteria, of course, they used Eolia criteria, a compromised PF ratio or hypercarbic state, and again, they used what we've learned, at least have blood flows, trying to achieve 4 liters per minute on the VV-ECMO circuit with larger cannulas, and then coagulate these patients to a higher anti-10L level than usually you do on VV-ECMO. So what happens if you don't recover? Here we have a patient that we actually are discussing in our center at the Jefferson Center City CVI ICU. And this patient's been on VV-ECMO for over 30 days. He's a young man. And you see here on the left-hand side, you see now the organization of fibrosing lung injury. You see a honeycombed pattern. You see in this, especially this follow-up slide, look at the left side again of your screen. You see these dilated bronchi because of the traction bronchiectasis present in this patient. The thought is that this patient's going to have irrecoverable lung injury at this point and should be considered for maybe lung transplantation, which, again, this is such a dynamic and fast-moving area. This just came out last week, an announcement of the first lung transplant that was done in Vienna by Dr. Walter Klepetko and his very seasoned team in Vienna. 45-year-old woman who was flown in with days on VV-ECMO not recovering. She had a necrosed, very sick lung, and she was successfully transplanted. She's about 1 month out now, and we'll be hearing about her in the update when we discuss again this Friday, 5 p.m. Central European time. We're going to discuss again these updated cases. Here in the U.S., a recent case just again came to our attention this past week. This case is from Northwestern. This is the case of a young woman in her 20s who was successfully transplanted, very ill patient. So we will see the follow-up to these cases over the next several weeks. I just want to basically just cover in 1 minute the question of what about cardiopulmonary support, full support in someone with cardiogenic shock. I want to make sure we're aware, and a great CVI Heartbites was given, which I listened to. Michael Levin, one of our fellows, when I was at Penn, I got a chance to meet him, work with him. He gave a fantastic overview of cardiac injury during COVID. So I'm not going through that. I'm just going to talk about the fact that this acute COVID cardiomyopathy is what encompasses when you see a positive troponin, when you see someone with RV-LV dysfunction, and it's very much not yet defined in terms of mechanism. So here's a case of a woman that we had on service while I was taking care of patients who we brought over from New Jersey. She had COVID-19 pneumonia and was on increasing doses of Levophed. She was treated initially with tocilizumab, and her troponin, high sensitivity troponin I was over 2,000. A point of care ultrasound showed an EF of 35%, and she was transferred on stable levofed at the time, but with worsening PF ratio. She was not a candidate at this age and with this degree of LV dysfunction for ECMO. This was some of the early days, and I still think we would not put this woman on VA ECMO at this age. So we treated her conservatively, and here's her echo when she first came in. You see the point of care ultrasound showing an EF that's compromised. Importantly, if you fast forward, this potential shape of Takotsubo. It was called Takotsubo, but it's also a foreshortened view. So we went on and gave her IV heparin, judicious diuresis. We actually proned her, which they did not want to do at the outside hospital. We proned her, and she improved. Her SpO2 throughout was above 70%, so she was not low output. And unfortunately, she's now had to undergo a tracheostomy, but she did recover heart function. This is important. She recovered heart function to an EF above 50%. And we were happy to see her recovery be and it's important to note that a lot of the recovery that we're going to go through and see in other cases, not in this series I'm presenting now, maybe in the future, the recovery is early here. It begs the question of, is this a myocarditis? Here's one last case I'm going to present, is a myopericarditis that was seen at the University of Michigan. I thank Ashraf Abu El-Ala, who is a cardiac surgeon there, for this nice report. This patient recovered, as you can see, very quickly, but here's her presentation. Again, young woman, female athlete, had symptoms for about 2 weeks, including syncope and chest pain. Her chest X-ray was unremarkable, but she did have some lateral, especially ST segment elevation, and her echo showed an EF of 10% with a moderate pericardial effusion. She was airlifted to the University of Michigan. Here was her echo, very sick, edematous looking echo, EF, very compromised, a stroke volume compromised, and a large pericardial effusion. Importantly, she had she was placed on levofed, high dose levofed, and she had a cardiac arrest, repeated, and came back. In the cath lab, they drained the effusion, but she was still very, very sick. Another PA arrest. Finally, she was placed on VA ECMO. This was her chest X-ray. Again, no evidence of COVID-19 pulmonary infiltrates in this COVID-19 positive patient with a acute cardiomyopathy. And again, looking at the CT scan, the EKG is presented here for you. You see the ST elevations that are present more in the first precordial leads, V1 and V2. You also see in the panel of biomarkers, you see a very significant increase in both troponin as well as the D-dimer and CRP, which ultimately came down. And importantly, they discussed her. What are we going to do if she does not recover? At that point, transplant was not being considered for these patients acutely ill. So the thought was we need to have a bridge to recovery platform. She got convalescent plasma, and she, according to our colleagues, began to improve. She was decannulated 8 days after being on ECMO, and she was also on mechanical ventilation of total of 11 days. Here's her echo, and here's a nice 3D reconstruction showing much improved. And now she is, from what I hear, doing very well. So thank you for this time with you to go over some of the updates on cardiopulmonary support in COVID-19. I just want to make sure that I thank colleagues. Here's a quick summary of what I just said. More than any other take home, please be certain that cardiopulmonary support can be achieved with mechanical support on ECMO in these COVID-19 patients. VV ECMO appears to be providing patients lung rest and a reasonable survival at this point. We have much more data to collect before we know who's most likely to do well with this. And again, an important lesson we've all learned is that our learning curve is being facilitated by collaborative engagement with colleagues. I want to thank from the ICE, the International Consortium for COVID-19 ECMO, my partners Joe Savino, Alan Combs, Nawar Al-Rawas, Ali Banayosi, and Marvin Slepian, as well as other colleagues. I also want to thank the CVI team and for their patience, and especially Marlo Polanski. Thank you. One last point here, for any questions, please email me directly, especially if there's any interest in joining the ICE consortium. Also, you can email our incredible administrative support, Yolanda Rabnell at jefferson.edu. And for other questions, please, comments or otherwise, please visit the website for CVI Heartbites or email Mark Hartnett directly. Thank you.